All right, so don't be too scared. Our next section, we titled it Inside the Mind of an MCO, which could be a scary endeavor. We might not all be up for it quite this early, but as I mentioned, my experience was on the provider side as we began this journey, and I was kind of, if you heard of the dog whisperer? When I went into the managed care world, I was a bit of a provider whisperer in those conversations. I would sit as an executive thinking, what are they saying? You can't say that. But it was interpreting, as Lindsay mentioned earlier, how do we speak the same language, right? So it was helping my colleagues in the MCO world understand this is what you're trying to relay, but this is what the provider's hearing, right? So I was able to, and Lindsay as well, we were able to really bridge a gap with partners like Raul. I mean, I sat in a lot of meetings, a lot of meetings with Raul and many of his colleagues. Again, that transition was not easy. No one's here to say that the transition was easy. There were bumps, but everyone wanted to do the right thing. But if you're not from the provider world, you don't understand that world. So we had the opportunity to say, we've been there. We just left there. This is what they're experiencing. This is why it's hard. This is what you don't understand as sitting in maybe the other side of the table as an MCO executive. So what we try to do with this section is help you understand how your organization will fit into the MCO business model. So I'm actually going to show you like what it looks like as from an organizational perspective. They're complicated organizations. And Raul touched on this, communication, communication, communication. And it has to go both ways. Many of the struggles, as Raul mentioned, it wasn't just one-sided, and the struggles that you may experience aren't going to be one-sided. Everyone has a role in making this work for our members and our communities. And then the value, and I mean, honestly, I don't think Audrey and Raul could have set the day up any better, and they didn't even see our slides, and we didn't see their slides, so it's great when you're aligned like that, but how does that partnership work, and what's that about, and what does that look like from the provider perspective? So these are the questions we hope to get us through here with this section. All right, so we're just gonna get the elephant in the room. We always know when we talk about managed care, the assumption is that they're there to deny care. How many of you have ever said that, or thought that, or heard that, right? Yeah, maybe a time or two, yeah. Well, I can assure you that that is a true myth. And as you listen to Audrey speak, and as Lindsay talked a little bit about the finance model, and I'll talk a little bit more about that, it's not the business model. I was the COO at Illini Care Health for many years, and my role was, I had profit loss responsibility. That was my role. I had care coordinators, the whole clinical team reported up through my organization, as well as the whole operations team. So I can assure you that neither of those roles in the organization were about denying care. Now, are there things that get denied? Yes, there are things that are going to get denied. I'm not going to stand up here and tell you that you're never going to have a denial. But there are reasons for that, and some of those, again, we have to take equal responsibility for those, and we'll talk through some of those. Some of those are more administrative, learning the organization, understanding the organization, and understanding managed care. But the role of managed care is really about coordinating care and showing how you can coordinate the care in a way that benefits the member. So let's look at... Sorry, I could really get on a soapbox about this, but anyway, I'll try to temper myself. So managed care defined. So if you Google what managed care is, what you're going to see is 3 key words. A system organized around quality, which you've heard already this morning quite a few times. Utilization, so the right care at the right time, which we've heard a lot already. And cost. So cost is a factor. But as we focus on quality and focus on utilization, that's the outcome of that focus. It's the outcome of that collaboration and that coordination. So financing of the MCO, you've heard Lindsay's example about the $100. So again, each MCO is paid a capitated rate. So myself and the CFO every month, well, when I was there, the state wasn't paying, but what we were supposed to get paid. So that was a whole nother era of the transition to managed care. But in any event, we would sit down and figure out what was our capitation every month. Were we getting the right financials from the state, and what did that look like? So every month you sit down and look at your P&L and your fixed capitated income, and figure out what was as Audrey gave you a little tip into that, what's your MLR? So what's your total cost of care for each of your members, and how does that look? Preventative care and focusing on prevention is a lot less expensive than having a member in crisis, having a member in the hospital. So those are things that really there was a lot of focus on. We had our medical management executives in the room, our leaders in the room, understanding how can we better coordinate the care? How can we communicate better? How can we partner with our providers? So we had more interaction to understand what was going on with certain members. So that is how the model works. Now, Lindsay talked about savings already built into your PMPM. So the MCO is going to get a per member per month. So for each person, they get a fixed dollar amount. They already take out what they call managed care savings. So that is what they're assuming you can save if you're coordinating care properly. They also take off a quality incentive. So they don't give you your full actuarially sound rate out of the gate. They withhold some of that, and you have to earn that back. And you earn that back through meeting quality triggers and quality incentives that are all contractually based. So right out of the gate, just understanding the managed care contract, denying care will not get them their full rate. Many of these are for-profit organizations, and their goal is to achieve the full financial benefit of serving these members, right? So just right out of the gate, their goal is to maintain and improve quality. Yes, they will essentially should be lowering the cost of care, but that's not necessarily what they're incentivized for contractually. Contractually, the MCOs are incentivized for coordination and quality of care. Any questions about that? All right. So again, this slide I could have put right into the Aunt Martha's deck as well. And so we do have some cartoons. Hopefully they won't be offensive. Most of them are poking fun at managed care, so we hope you won't find offense to them. But we do have some funnies thrown out throughout the day. We figured this is a little bit of a serious topic, a lot of information, so we thought we'd give us some levity once in a while throughout the deck. So this particular one says, it looks like you're in need of some managed care as the physician is assessing the member there. But as Raul and Audrey mentioned, data is something that the MCOs have. So the MCOs receive data from every single provider or entity that touches the member. So as a provider in the community, that's not information you're privy to, right? You don't know, are they getting their prescriptions filled? What other providers are going? How many times they've gone to an urgent care? Have they gone to the ER? Did they do a HRA, a health risk assessment? What was the results of that? What was the results of their survey? Their primary care. So there's so much data that lives in a managed care organization, and that whole idea of moving from volume to value is with this. How can we improve outcomes with this data? How can we reduce duplication? How can we coordinate? And so the data should go both ways. As Raul was mentioning, you should say, I'd like to know when my members or when my patient is in the hospital. That will help you better coordinate that care. So it shouldn't be one-sided. Yes, there is an opportunity for a holistic approach because all the data is coming into the MCO, but that is an opportunity for you as providers as well, is to ask for that data back. So when you talk about collaborating or partnering, that's data that's on your patients, that you have every notion to ask for something like that. But the whole idea is how can we improve the outcome by knowing this data. So you know you wrote a prescription for a member or a patient to fulfill their prescription. You don't know if they ever went to the pharmacy to get it. The MCO does. They can tell you how many times they filled it, or if they ever filled it. Or does another provider prescribe a different medication that overrode the medication? Because again, the pharmacy's making decisions too, because they're receiving, if they happen to go to the same pharmacy, they're getting all that data too. So this is just an illustration to show you how those arrows should really go both ways. Data that you can have as a provider, that the MCO they have a whole analytics department that is looking at this data on an ongoing basis to better understand what are the needs of the members and the patients that you serve. The other area which was touched on earlier is care coordination. So that you may have care coordination in your provider office or your facility, but the MCOs also have care coordination. And so having those care coordinators work together is the ideal situation, the ideal scenario. From an MCO perspective, they are required to have a approved care coordination model. So HFS approves their model and how they're coordinating care. They also they are contractually required at certain staffing levels for care coordinators and care coordination based on the level of members that they serve. The last thing that's contractually, there's three things, what did I say? HRAs and HRSs. So the membership has to have an HRA, health risk assessment, or a health risk survey, depending on the level of stratification they are, on an ongoing basis. So they have to have a certain percentage of those for new members, existing members. So all of that is monitored and is contractually required. And the whole point of that stratification, as was mentioned earlier, is to really make sure the right members are getting the right care at the right time. So your higher risk members have a different care model. They have a different care coordinator ratio on how many members they can actually oversee. So again, that is a great opportunity for providers and for the MCO to work together on that member's care. And how can we how can they best receive that care? These are just examples. You saw the Aunt Martha's one as well, the member in the middle, the patient in the middle, making sure that they're getting the right resources at the right time. And many times, it was mentioned earlier, it's not always care that they need. They need a coat. They need a place to live. You know, those social determinants are so critical, and those partnerships are critical as well. And just as Aunt Martha mentioned, those partnerships, many of the MCOs are also working in that community to try to facilitate some of those needs as well. But I think what's important here is that I gotta get used to this remote here. That whole provider MCO partnership, that is really the key, and that is what's going to take managed care to the next level, improving those outcomes by working together. So you may be asking, so what is my role? And your role, as providers, you are delivering care. The MCOs in Illinois do not deliver care. No, none of them are delivering care. You have eyes on the member. The MCO may have data, but you are the ones in the office, in the community, one-on-one with those clients or those members. So that is definitely the role that you bring. Now, what else could you bring besides that traditional care delivery? Member engagement is also something that is mentioned. They may need other services. You may want them to participate in redetermination, which we'll get to later, but it's important for them to keep their benefits. So that may be a role that you have with the MCO, is helping with enrollment and making sure members receive their benefits. Collaboration, again, another collaboration and coordination, working with the MCO, working with your other community partners. And we actually saw, this is kind of a continuum, and Aunt Martha's is all the way at the bottom here with innovation. They're coming up with new ideas to engage with the MCOs, new ideas to engage with the provider community, other community partners. So there's lots of different places where the MCO and the provider can engage together, and it has to be that two-way conversation on how and what can you bring to the table that will help, again, improve that quality for that member and potentially reduce costs. So as Lindsay mentioned, some of the health choice data is not quite in, but there was some official data on the MMAI population, which I know is a different population. Those are the dual eligibles, those who have both Medicaid and Medicare. But this was an innovative innovation project across the country with CMS. And what recently just came out was they had an independent evaluator come into Illinois and determine, is managed care having benefits for the MMAI population? And these are some of the results. So HFS had nothing to do with this, the MCOs had nothing to do with this, but their results were they saw almost a 15% decrease in inpatient admissions, 7% decrease in ER utilization, 10% decrease in preventable ED admissions, which I think is a great statistic there, And in this population, it makes sense, almost a 9% decrease in skilled care admissions. So when all of the players work together, when you have that coordination, when you have that partnership with providers, you will see benefits. Now, they didn't focus on reducing costs, they focused on improving quality, and then the cost was just a side benefit of all that hard work and all that collaboration. So with these results, CMS decided to expand the duals program throughout the whole state of Illinois, so the innovation project will continue here and will be expanded throughout the whole state, because these are the benefits that both CMS wants to see as well as HFS. So I think that's super exciting, what's on the horizon for health choice. So this is just an organizational structure, as was mentioned by both Raul, and Raul was about building those relationships, building those partnerships with the MCOs. But MCO organizations are complicated. There's lots of different people in lots of different places with lots of different roles, right? So we just put this up here just to kind of help you navigate. Now, everyone's structure is going to be different. Many of these organizations also have corporate entities, which can even complicate things more. But what we wanted to show is that they all have a clinical arm of their organization. They all have an operations arm. They have a provider space in their organizational structure, and then some general administration. But what you'll want to find out as you build these relationships, as you start working with these organizations, is where can you connect? And where should you connect to get the questions answered that you might have? So many times they're going to put you with provider relations. That's usually your entry point into an organization, whether you're beginning to do a contract, whether you have particular issues or concerns. They'll usually have you start with your provider relations. But if your issues aren't getting resolved, it's important to understand the larger picture. And what happened earlier in the managed care is folks would stay with the provider relations, not get what they needed, and then things started to blow up. So you got to figure out the organization and where you can best insert yourself from a provider perspective. The other place quality is also an area. If I were in your shoes, I'd want to know the quality data on my members or my patients, because they're going to have a holistic view of the quality. You'll have how they operate in your particular facility, but they'll have a broader based information. You could ask for data on the quality of your patients. Sorry, it's hard to members, clients, so it's all the same thing. Care management and utilization management, also places where you're going to want to intersect with the MCO organization. So if your provider organization has members that utilize hospital services, you're going to want to know who in would be a good point of contact for you, so you could, again, navigate their discharge, their post-discharge treatment, things of that nature. Care management's another one. The care management department is who's doing all those HRAs and HRSs. That's their responsibility. They'll have a whole wealth of information on your particular members. And you may have, from your perspective, high-risk members. Connecting with them on those members would be a great first step into the organization. Now, they'll have for you, I wouldn't necessarily dive into this as Managed Care 101, the MLR information. That'll come down your journey as you work with managed care. But again, they can tell you as a provider what is your MLR for your patient base, because every member is assigned, and they can tell you that. So some of you may want to know that. Some of you may want to wait to find that out. But it definitely gives you a roadmap, because again, they're looking at these patients, these members holistically. So some of it's within your span of control and some of it's not. But to better understand that and where to intersect in the organization is really going to benefit you from the long run. And all of them have analytics. So that is a key department. You won't necessarily have interaction with them, but know that they're in a room looking at this data 9 ways, as Lindsay was just saying, 9 ways to Sunday. That's what Lindsay says. So they're looking at your data all kinds of different ways on your members, and that team is really charged with understanding what's happening with each of the members. All right. So these are just some general tips. Most of these, I think, are maybe self-explanatory, but building those relationships. So as you begin the contracting process, they're going to transition you off from the networking team to the provider relations team. That's a normal handoff. Then from there, as you begin working with your provider relations team, understand who else you want to interact with. You may want to interact with the quality person. You may want to interact with the medical director, depending on your agency or your services. But again, understanding who those key people are in the organization will save you a lot of anxiety down the road if you do run into some barrier. Open, two-way, clear communication. What I found many times is that communication would stop one way or the other. So as COO, if I got called into a provider meeting, so I was called into a provider meeting with Raul, if they go all the way up there, you know you've got a problem. So when Raul called me directly, I was like, oh, good Lord, because it should always be solved before it would get to me. But we worked things out. We understood. Again, we shared data both ways. We built a general understanding what was working on the MCO side, what was working on the provider side, and what wasn't working. So it was a two-way discussion. There were things that Aunt Martha's was going to do differently. There were things that the MCO was going to do differently, and then we came together. And now look, we're good friends. We've come a long way. But again, that two-way communication, that open and clear, put all the cards on the table. This is where I'm struggling. This is where I need help. This is where we think you can help us. But keeping that ongoing open communication. Document, 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 document. What I found as I transitioned to the managed care world, there were a lot of issues, but there was no documentation. So a provider would come and say, I've already talked about this. And I said, okay, cool, can you show me something? Show me a letter, show me an email, show me something. Because I wasn't at the MCO 5 years ago. I just got there today. So my tip for all the providers that I've worked with, pre and post MCO and our clients, document. Keep documentation on things that you agree to, conversations you have, emails, and so forth, because that will be your best recourse if something were to happen. Now, a lot of those things have cleared the way, but it's still not perfect, right? So my number one piece of advice is document and keep things. You're going to have transitions in your organization too. Make sure you have files that can transition from one person to another so that you don't have barriers that you can't overcome. We'll talk about this more as we get into the nitty-gritty, but monitoring your payments, monitoring the revenue from each MCO, what's coming in for what's not coming in, what's missing. You have to have the infrastructure to support the payment process. Otherwise, you'll have difficulty with your relationship with the MCOs. And then the final one is just remember that the MCOs are incentivized for quality. Their interest is in quality of the member, improving quality for the member, and not just the cost. And they're not there to deny care. They're there really to work with you. And we're going to talk about utilization and care coordination and that a little bit later. This is just a general flavor for you. All right. So, how was it being inside the mind of an MCO? It's not too scary, right? What questions might you have about how to navigate with an MCO partner?
I should have jumped earlier, sorry.
Oh, that's fine.
Hi. So this is something I've heard. I have no direct experience, so if it's inaccurate, please correct it. But I've heard sometimes there's a lot of turnover in the MCOs, particularly at that first point of contact with providers. Mm-hmm. What advice or recommendations do you have if we're experiencing that, which can be challenging in building those relationships and having those conversations long term?
Yeah, that is a true statement. Provider relations is a role that sometimes has turnover. They sometimes go to other MCOs, and it's always a battle of, because they're a very skilled resource, they have to know a lot about a lot of things. And so as the MCO world was expanding, those folks were getting lured away for different reasons, right? But I think some of that's died down a little in my experience. Things are going to transition now that the MCOs are there's going to be less of them and consolidating. So we might see a similar face at a different organization, which has happened to me more than once. But I think that the point is documenting. So if you have your documentation in order, most of them are required even from HFS to have some sort of transition, because that was a significant issue from the provider perspective. But they've asked the plans to have a better transition strategy as provider relations reps do leave the organization. But I think, again, for you to have your own documentation is going to be key. So having your own file with your open issues or your questions that you've presented is going to be the best recourse for you if there is transition within the MCOs. I think that that's what I've seen work best. I mean, if a provider came to me with an email stream for 2 years, I really didn't have much. Thank you for being so diligent, because I wasn't here for those 2 years that this was going on, So it was really helpful. But the providers that just showed up with a blank sheet of paper, I had no, the conversation had to start all the way back over again, which was frustrating for the provider. But being on the other side of the table, I didn't have any document. I had no information to assist them. So that's why my advice is to make sure you have your documentation for each MCO, who you talk to, when you talk to them, what you agreed to, save emails, and ask them to. What I did on the MCO side is, after I would meet with the provider, I would summarize our conversation. This is what we talked about. This is what we agreed on. Please respond. If I don't hear from you, I'll assume that this is accurate. So I wanted to give them an opportunity to respond, but at the same time, if they didn't respond, I didn't want it to be like this meeting never happened. So, that's just a suggestion that worked for me, which may work for you as well. Yeah, good question.
So I just wanted to add to that. It is a true statement, I would agree. The other thing that I would say is if you're new to the whole Medicaid billing, a lot of the conversations you're going to have with your provider relations rep are going to be about claims and billing. Mm-hmm. And again, documentation, we can't overemphasize that. But what I would say is, if you are, and Carrie, I think the meetings will continue. Every other Monday, we have meetings with HFS. I'm there on behalf of I'm HIP. Carrie's there on behalf of ICOI. I call them affectionately the meetings from hell. We start as MCOs as an industry at 8 a.m. and often go straight through to 5:30 with no scheduled breaks. But each of the associations will come in and they have a spreadsheet of members' billing issues. So if you're having trouble communicating with the MCO provider rep, or they've disappeared, please let your trade association, whether it's ICOI or IABH or IR for whoever you may. Oh, well, there you go. Carrie will take she'll take all comers.
And
then the final thing I would say, and it is in the billing manual, and we'll talk a little bit about the billing manual, there's always an escalation process, yes. And there's in the billing manual contact information if you need to escalate an issue.
Yeah.
So that was the only thing I wanted to add.
Yeah, great. Any other questions on this section? Because now we start the real details. All right, Liz?